Welcome back to the deep dive. We take complex stuff, break it down, and hopefully you walk away with some really fascinating insights. Today, we're really going deep, right into the core of things, the rhythm of our hearts. Our mission, really, for this deep dive is to get a serious handle on sinus tachycardia, to understand it like the absolute top pros in the field. We've got chapter 24047 here, Physiologic and Non-Physiologic Sinus Tachycardia by William H. Sauer and Paul C. Zai. Really solid stuff. This material should give you, a real shortcut to being properly informed on a critical cardiac topic.
Absolutely. And it's fundamental, isn't it? Understanding the heart's normal beat and, well, when it speeds up or goes off track, so many people feel their heartbeat, sometimes uncomfortably so, and immediately think, is this an arrhythmia? Is something wrong?
Mm-hmm.
Today, we want to clarify what's normal, what's just your body responding appropriately, and importantly, what might signal something a bit more elusive, something needing a closer look.
The heart's natural pacemaker unpacking the sinus node normal rhythm.
Okay, let's start right at square one. To get tachycardia, we first need normal rhythm, right? The sinus rhythm. That means the beat starts in a specific spot. What is this sinus node, and where exactly is it?
Right. The sinus node is, it is the heart's natural pacemaker. Think of it as the command center setting the pace. It's a tiny cluster of specialized cells, and its location is incredibly precise. It's in the lateral superior aspect, so kind of the top outer edge of the junction between the right atrium, that's the top right chamber,
Okay.
and the superior vena cava, the big vein bringing blood back from the upper body. More specifically, it's nestled right within the top part of this thick ridge of muscle called the crista terminalis.
Crista terminalis.
Yeah, it's a key landmark. It marks where the smooth back wall of the atrium meets the more muscular, ridged front part. This very specific location is crucial for the electrical signal to start correctly and spread out evenly across the atria, like dropping a pebble in just the right spot in a pond.
Wow, that is a precise address. So this pacemaker activity, how does that show up on, say, a standard 12-lead ECG? What does normal sinus rhythm actually look like on the printout?
Yes, the ECG signature. Normal sinus rhythm has very distinct features, especially the P wave. The P wave, that first little bump before the big spike, represents the electrical activation, the depolarization of the atria, starting from the sinus node. So you'll see positive upward P waves in leads Y2 and 3 generally, but specifically positive in leads 2, 3, and AVF. Those leads look at the heart from below.
Okay, positive from the bottom view.
Exactly. And conversely, you'll see a negative downward P wave in lead AVR, which looks from the upper right. In V1, the chest lead over the right side, the key wave is often biphasic, starts positive, then goes negative. This whole consistent pattern, positive below, negative in AVR, tells you the overall electrical direction, the axis, is heading down and to the left.
Which is exactly where it should be coming from if it starts in the sinus node.
Precisely. It's the confirmation that the heart's own pacemaker is in charge. And of course, the rate. For normal sinus rhythm, we're talking 60 to 100 beats per minute at rest. That's the standard range.
Right. So this specific P wave shape, this direction, and that 60-100 rate range. That's our baseline, our definition of a healthy, regular heartbeat starting correctly. Understanding that foundation feels absolutely critical for everything else we're about to get into, doesn't it?
It's non-negotiable. It's the yardstick. Without knowing what normal looks like, you can't possibly identify abnormal or even appropriately different. Everything gets compared back to this baseline.
Physiologic sinus tachycardia, the body's appropriate response.
Okay, now let's tackle tachycardia. Simply means fast heart rate, over 100 beats per minute. But when does sinus tachycardia become physiologic? What defines that, and what's actually happening inside us when our hearts speed up appropriately?
Physiologic sinus tachycardia. It's still a sinus rhythm, starting in the right place, but the rate is just over 100. The key word is physiologic. It's the speed up is an appropriate expected response to what the body needs right then. It's not a malfunction, it's adaptation.
Like the body hitting the gas pedal.
Exactly. The mechanism involves more sympathetic stimulation, think adrenaline, your fight or flight system kicking in, and at the same time there's less vagal tone, that's your rest and digest, parasympathetic system backing off, so more gas, less brake. This combo speeds up how quickly those sinus node cells spontaneously depolarize, how fast they fire off naturally. And what's really interesting is that the exact spot within the sinus node where the impulse starts first actually shifts slightly. It moves a bit more leftward and closer to the septum, near the top of that crista terminalis ridge.
A physical shift.
A subtle one, yes. And you can sometimes see it on the ECG. It tends to produce taller P waves in those inferior leads we mentioned, compared to resting rhythm. A little clue, it's physiologic stress. And just as a side note, the opposite, sinus bradycardia under 60 beats per minute can also be totally normal. Think deep sleep or really fit athletes, their hearts are just very efficient at rest.
Right, so it's context dependent. So this physiologic tachycardia, the appropriate speeding up, what are some common everyday triggers? And when might someone actually go see a doctor about it? Feeling your heart pound can be scary.
Oh, absolutely. It can be quite alarming if you're not expecting it. It's considered physiologic when it's clearly linked to common stressors. Intense exercise is the classic one, obviously. Emotional stress, anxiety, fear, excitement. Even something like acute pain or running a fever. Your body's metabolic demands go up, so the heart compensates. Patients often seek medical help because, as you said, they feel it. That uncomfortable awareness, the palpitations, it can feel like fluttering, pounding, racing.
Even if it's technically normal for the situation.
Exactly.
Yeah.
And sometimes the symptoms are so strong people worry it's something more serious, like other kinds of supraventricular tachycardias or even ventricular ones. The symptoms can unfortunately overlap.
Okay, that raises a really important point. How do you tell this appropriate physiologic response apart from other fast heart rates? You mentioned focal atrial tachycardia earlier, if that starts near the sinus node. How do you differentiate?
That's a key challenge. It could be tricky, especially if the focus is right next door to the sinus node. The P waves might look very similar, but a big clue often is the onset and offset, how it starts and stops. Physiologic sinus tachycardia usually ramps up gradually and ramps down gradually. Think about starting exercise. Your heart rate climbs steadily, then comes down slowly as you cool down. Smooth transition.
Makes sense.
Focal atrial tachycardia, on the other hand, tends to have an abrupt onset and offset, like flipping a switch. Suddenly fast, suddenly normal again.
Oh, okay. The pattern over time is different.
Right. Sometimes it's so subtle, though. You need longer ECG monitoring, like a Holter monitor, for 24 or 48 hours to really see that pattern. And in really tough cases, you might need an invasive electrophysiology study. Go inside the heart with catheters to map the electricity and pinpoint the exact origin. Figure 24/7-2 actually shows this difference quite well.
Okay, so if it is determined to be physiologic, the body just doing its job, what's the treatment? Is there one?
Generally, for physiologic sinus tachycardia, the treatment isn't aimed at the heart rate itself. It's aimed at the underlying cause. If someone has a fever, you treat the infection causing the fever. The heart rate comes down as they get better. If it's driven by anxiety, then managing the anxiety is the key. Often, if the cause is temporary and resolves like recovering from an illness or a stressful period, passing no specific heart rate therapy is needed at all. The body just resets itself.
And this sounds critical. There are some serious underlying conditions that can cause sinus tachycardia, right? Things a doctor absolutely has to rule out before saying, oh, it's just physiologic. What are those big ones?
Absolutely vital point, yes. Before you label it benign, you must exclude serious reversible causes. Top of the list are things like abnormal thyroid function, specifically hyperthyroidism. An overactive thyroid floods the body with hormones that directly speed up the heart. Very common cause.
Okay.
And anemia. Low red blood cells means less oxygen delivery per beat, so the heart has to pump faster to compensate. Again, common and treatable. Then you have to think about structural or functional heart and lung issues. Big one is pulmonary embolism, a blood clot in the lungs. The heart races to try and overcome the blockage and get oxygen. Life-threatening.
Right.
Also, a myocardial infarction, heart attack, pericarditis, inflammation around the heart, significant valve disease, or decompensated heart failure. All these put immense strain on the heart, causing it to speed up. Even shock from various causes. These are emergencies that need immediate attention.
So a huge checklist to go through first.
Absolutely. Only after ruling out these serious treatable conditions can you start thinking about other possibilities like IST or POTS. And remember, people just have different baseline heart rates. A slightly high rate in someone with no symptoms and no underlying cause might just be their normal and doesn't need treatment.
That list of causes is enormous. Table 24/7-1 in the source seems to lay it all out. Can you give us a rundown of those categories? It really paints a picture of how many things influence heart rate.
Yes, that table is fantastic. It breaks it down nicely. First, the physiologic causes we've mostly covered. Emotion, exercise, sex, pain, even pregnancy due to increased demands. Normal responses.
Right.
Then, pathologic causes. These are actual medical conditions triggering the tachycardia. Anxiety, panic attacks, very common. Anemia, fever, dehydration, infections. Even malignancies, cancers can cause it systemically. Hyperthyroidism, hypoglycemia, low blood sugar. Some rare endocrine things like pheochromocytoma or Cushing's. Diabetes, especially if it affects the autonomic nerves. And those critical cardiovascular events, pulmonary embolus, heart attack, pericarditis, valve disease, heart failure, shock, even alcohol withdrawal that can cause a major sympathetic surge.
Wow. Okay, what else?
Next category is drugs. Lots of medications can do it. Things like epinephrine, dopamine-powerful stimulants, atropine, which blocks the brake. Asthma inhalers like salbutamol can have spillover effects on the heart. Methylxanthines, think caffeine, theophylline, certain chemo drugs. Even stopping beta blockers suddenly can cause a rebound tachycardia. And common stuff. Caffeine itself, alcohol.
And finally, illicit drugs.
Yes. Illicit drugs are a major cause. Amphetamines, cocaine listed twice in the table, really highlighting how common and dangerous it is. LSD, psilocybin, ecstasy too, it's just a huge spectrum. Shows how interconnected the heart rate is with everything else, physiology, pathology, pharmacology. You have to consider all of it.
Non-physiologic sinus tachycardia, diving into inappropriate sinus tachycardia, IST.
Okay, that really sets the stage for appropriate responses. Now let's shift into the more complex area. Non-physiologic sinus tachycardia, starting with IST, inappropriate sinus tachycardia. What exactly defines this and why inappropriate? What makes it different from all those causes you just listed?
Right, IST, it's considered uncommon, but it can be really challenging for patients and doctors. It's defined by a sinus rate that's high at rest for no apparent reason, or it shoots up way out of proportion to minimal exertion or stress. The key is inappropriate because, unlike everything we just discussed, there's no identifiable appropriate underlying cause. You've ruled out the thyroid issues, the anemia, the drugs, the PE, the anxiety, everything. Yet the heart rate is still persistently high.
So it's a diagnosis of exclusion.
Exactly. You have to exclude all other explanations first. It seems to fall under this umbrella of autonomic dysregulation, an imbalance in the body's automatic control system. The accelerator and brake aren't coordinating properly.
And the source says the exact mechanism is still elusive. We don't fully know why this happens.
That's right. It's still being researched. The leading theories point towards that autonomic imbalance we mentioned. Maybe there's too much sympathetic drive the accelerator is stuck on. Or maybe not enough parasympathetic tone, the brake isn't working well enough.
Or both.
Or potentially both, yes. Another idea focuses on the sinus node cells themselves. Maybe they are intrinsically faster. Their natural automatic firing rate is just set higher for some reason. Could be altered membrane properties, making them inherently more excitable. It's likely complex, maybe a mix of factors. And this uncertainty makes treatment tricky.
Who typically gets IST? And what does it feel like for them? Must be quite disruptive if your heart's racing for no reason.
It is very disruptive. It often affects women, typically in their 30s or 40s, though it can occur in others too. And the symptoms can be really debilitating. Palpitations are almost always the main complaint, that constant feeling of a racing or pounding heart. It can be exhausting.
I can imagine.
And often it comes with other things linked to that autonomic dysfunction. Profound fatigue, dizziness, lightheadedness, sometimes even fainting or syncope. Plus, people might report chest pain, though usually not cardiac, headaches, even GI upset. It's a systemic issue, really. Affects quality of life significantly.
With symptoms like fatigue and dizziness overlapping with so many things, how hard is it to distinguish IST from, say, physiologic tachycardia due to severe anxiety, or even that focal atrial tachycardia near the sinus node? Sounds like a diagnostic nightmare.
It really can be. Differentiating it, especially from anxiety disorders, is very challenging because the symptoms overlap so much. You look for clues like the heart rate being persistently high, even at rest when the person feels calm, or the sheer degree of tachycardia being wildly out of proportion to any mild stressor. And differentiating from that nearby focal atrial tachycardia often relies again on that onset-offset pattern. IST tends to be more gradual or persistent, while focal AT is often abrupt. But it might still require that Holter monitor or even an EP study in complex cases. It demands careful, systematic exclusion.
Okay, so given this complexity, what are the treatment options? You mentioned it's tricky. Are they effective?
Yeah, unfortunately, treatment is often not fully effective or can be poorly tolerated. It's often a process of trial and error. The first line is usually trying to slow the heart rate with medications. Careful titration meaning starting low and going slow with beta blockers. Or calcium channel blockers, trying to find a dose that helps symptoms without causing too many side effects like fatigue or low blood pressure.
Are there other meds?
Yes, sometimes others are tried. Clonidine, which works centrally to reduce sympathetic output. Even SSRIs, typically used for depression and anxiety, have been explored, suggesting that link to broader nervous system regulation.
Now, this drug, avabradine, sounds particularly interesting. You mentioned it targets a specific current. How does that work for IST?
Ivabradine. Yes, it's quite targeted. It specifically blocks the if current, the funny current in the sinus node cells. This current is what gives pacemaker cells their automaticity, that ability to spontaneously depolarize and fire. It's like their built-in self-starter.
Okay.
By blocking this current, ivabradine directly slows down that spontaneous depolarization rate. It makes the sinus node fire less frequently, lowering the heart rate. The advantage is it does this quite selectively, without much effect on blood pressure or heart muscle contractility, which can be issues with beta blockers. While it's mainly approved for heart failure in the US, it's shown good promise off-label for IST, offering a more specific way to control the rate.
What about more invasive stuff? Catheter ablation, targeting the sinus node directly.
Ablation has been done for IST, yes. It involves trying to modify the sinus node tissue to slow it down, but, and this is a big but, its long-term success for controlling IST symptoms is generally poor. It's often not a durable fix.
Why is that?
Probably because IST isn't usually caused by one single faulty circuit that you can easily zap. It's often more diffuse. Either the whole node is intrinsically fast or the autonomic inputs are the main problem. Ablation doesn't fix the autonomic imbalance, and importantly, it carries significant risks. You could overshoot and cause symptomatic bradycardia, a heart rate that's too slow, or chronotropic incompetence. The heart can't speed up properly when needed, like during exercise.
Which could mean
Needing a permanent pacemaker. That's a major outcome you want to avoid if possible. So ablation for IST is really a last resort for very severe refractory cases after a very thorough discussion of the risks and limited benefits.
postural orthostatic tachycardia syndrome, POTS, a distinct autonomic disorder.
Okay, let's pivot to another non-physiologic condition, one that often gets confused with IST but is different. POTS, postural orthostatic tachycardia syndrome. What defines POTS, especially that postural part?
Right, POTS, another autonomic disorder, but the trigger is key. It's characterized by symptomatic sinus tachycardia that happens specifically when you change posture, typically going from lying down to standing up. There are specific diagnostic criteria. Within 10 minutes of standing, your heart rate has to increase by at least 30 beats per minute, or go above 120 beats per minute total.
So a very specific, measurable jump on standing.
Exactly. And crucially, this happens without significant orthostatic hypotension, meaning your blood pressure doesn't drop dramatically when you stand. If blood pressure plummets, that's usually a different issue. So POTS is really this exaggerated heart rate response to standing without the blood pressure drop you might expect to cause it. The heart seems to overcompensate.
And the symptoms, are they similar to IST, adding to the confusion?
Yes, very much so. That's a major reason they get confused. Patients with POTS also often report those debilitating palpitations, dizziness, lightheadedness, fatigue, brain fog, sometimes even fainting, but specifically triggered or worsened by standing up or prolonged standing.
So the trigger is the main differentiator, symptom-wise.
Precisely. The context of when the tachycardia and symptoms occur is critical for diagnosis. It often requires that tilt table testing to confirm the pattern.
What about the cause of POTS, and can it go away? You mentioned something hopeful there.
Yeah, the cause is thought to be related to autonomic dysfunction like IST, but perhaps with different drivers. Sometimes it seems to follow a viral illness, suggesting some kind of post-viral autoimmune or dysautonomic process might trigger it in some people. But it's likely heterogeneous, different causes in different people. The hopeful part is that yes, in some cases, particularly those post-viral ones, POTS can resolve spontaneously over time, maybe 3 to 12 months. Not always, unfortunately. For some, it's chronic. But that possibility of remission is important.
How is POTS treated then? Does it differ a lot from IST, given the mechanism seems different? Why things like SALT?
Yes, the treatment is quite different because it targets the presumed underlying issue problems with blood volume regulation and autonomic response to gravity, rather than just the sinus node itself. So big focus is on volume expansion. This often means a high-salt diet, like 8-10 grams a day, and drinking lots of fluids, 2-4 liters.
To increase blood volume.
Exactly. More volume means less relative pooling of blood in the legs when standing, keeping more blood circulating to the heart and brain. Medications like fludrocortisone can help the kidneys retain salt and water, boosting volume further. Compression stockings are key to physically squeezing the legs and abdomen to prevent blood pooling and aid its return upwards.
Makes sense.
And the drug midodrine can be used. It's an alpha agonist that constricts blood vessels, again helping to prevent pooling and maintain blood pressure on standing, reducing the need for the heart to race. And really importantly, exercise training. often starting with recumbent exercises like swimming or cycling, to build cardiovascular fitness and muscle tone without triggering the standing symptoms, gradually improving tolerance.
That's a very different toolkit than for IST. So why is getting that diagnosis right, POTS versus IST, so absolutely critical? What happens if you mix them up?
It's absolutely critical because, as you see, the treatments are aimed at totally different problems. Getting it wrong is ineffective at best, potentially harmful at worst. Think about it. If you misdiagnose POTS as IST and try sinus node ablation, it won't work. Ablation doesn't fix blood pooling or autonomic vascular issues. You might just end up with a slow heart rate, plus all the original POTS symptoms, maybe needing a pacemaker for no real benefit to the POTS itself.
That is
right. And conversely, if you misdiagnose IST as POTS and push fluids, salt, and midodrine, well, IST patients don't typically have low blood pressure or volume issues as the primary problem. You could potentially cause fluid overload, high blood pressure, or other side effects without addressing the actual rapid sinus rate.
So applying the wrong treatment strategy is just completely counterproductive.
Exactly. Precision in diagnosis is everything here. It dictates the entire management plan.
Comprehensive approach to sinus tachycardia evaluation and treatment pathways.
Okay, this has been incredibly clarifying. So pulling it all together, for that medical professional faced with someone presenting with sinus tachycardia, how do they navigate this? What's the systematic approach, like the one outlined in Figure 24-7, Act 3?
Yes, that systematic approach is key. It prevents missing things and ensures you land on the right diagnosis and treatment. Step 1, absolutely non-negotiable. Identify and aggressively treat any reversible causes of appropriate sinus tachycardia. That means going back to that huge list. Physiologic stressors, pathologies, drugs. Take a meticulous history. Do a thorough exam. Order the right tests, thyroid function, blood count, maybe chest imaging, ECG, checking medications.
Rule out the big treatable stuff first.
Exactly. Rule out hyperthyroidism, anemia, infection, PE, heart attack, heart failure, drug effects, severe anxiety. If you find one of these and treat it effectively, the tachycardia often resolves. Problem solved. That's always the first goal. Okay, but what if you do all that and there's no clear reversible cause?
Right.
If, after that exhaustive workup, you haven't found an underlying cause, then you move to step 2. Step 2 is evaluating for that spectrum of inappropriate sinus tachycardia syndromes primarily, distinguishing between IST and POTS. This involves digging deeper into the symptom patterns, the triggers, especially postural change, maybe doing those orthostatic vital signs carefully, perhaps longer ECG monitoring, or that definitive tilt table test if POTS is suspected. Is the tachycardia persistent at rest, suggesting IST, or is it predominantly triggered by standing without a BP drop, suggesting POTS?
And once you've made that distinction, IST or POTS, the treatment path forks, right? It becomes tailored.
Precisely. That diagnostic clarity dictates the specific management strategy. If the diagnosis is POTS, the treatments focus on those strategies we discussed. Recumbent exercise program, high salt, high fluids, compression stockings, maybe fludrocortisone or midodrine. It's all about managing the orthostatic intolerance and volume regulation. But if the diagnosis is IST, the approach is different. Initial therapy involves trying to slow the heart rate directly with medications like beta blockers or potentially ivabradine, careful titration, finding the right balance, and only if those medications fail and symptoms are severe would you even consider catheter ablation, always weighing those limited success rates and significant risks, like needing a pacemaker. The absolute key, the core principle here, is avoiding that mismatch. Don't treat POTS like IST, and don't treat IST like POTS. The systematic evaluation prevents that error.
Wow, what an absolutely fascinating deep dive into the heart's rhythm. We've gone from the precision of the sinus node through the body's normal accelerations in physiologic tachycardia and into these really complex, challenging realms of IST and POTS. It really hammers home how crucial that accurate diagnosis is. The entire treatment pathway hinges on getting it right. Just incredible complexity in what seems like a simple, fast heartbeat.
It really does. It highlights the sophistication needed here. It's not just about seeing a fast rate on the monitor, it's understanding that whole interplay, the autonomic nervous system, the specific cell biology, the potential underlying diseases, the patient's specific symptoms and triggers. Truly getting this right involves connecting all those dots, ruling things out systematically, and applying these detailed insights to the individual. That's the art and science of it.
And that really is what being well-informed means, isn't it? Understanding the nuances, the connections, the challenges. So here's a final thought for you to consider. How do these tiny shifts in your heart's pacemaker, speeding up appropriately for a run, or perhaps misfiring inappropriately in IST or POTS, reflect this constant, hidden conversation happening between your brain, your nerves, and your heart? How does this intricate signaling shape your feeling of wellness every single day, mostly without you even noticing the complex dance going on inside? Just something to think about. Thank you for joining us on this deep dive. Until next time, keep exploring, keep questioning, and keep learning.